Gecko session on hepatocellular carcinoma that's hosted by the Gastro Foundation Association with Project ECHO and the University of New Mexico. These sessions are held weekly on a Wednesday, and the chat will be open for questions. If you have any questions, please feel free just to post them on the chat, or we'll take them at the end of each talk. So there's going to be three presenters. I'm going to talk about the updated BCLC criteria. Wang Mtumkulu is going to present a case and speak about retasting patients, and then Sanju Sobnach, who's also one of our fellows, is going to present a case and talk about lung metastases in hepatocellular carcinoma. I'm just going to try to share my screen. Sorry, 2 seconds. So, like I said, I'm talking about the 2022 BCLC update. What's changed and what are the limitations of the BCLC criteria that are so frequently quoted and used for the management of patients with hepatocellular carcinoma? So the purpose of a staging system is to estimate prognosis, aid in treatment planning, allow for evaluation of treatment results by comparing patients with similar stages of disease, facilitate exchange of information between different centers, and to contribute just generally to investigation and research of patients with cancer. For most cancers, the stage is determined primarily by the anatomical extent of the disease. But hepatocellular carcinoma is a little bit different in that treatment and the stage is affected by the underlying degree of the liver function and the performance status and cancer-related symptoms. You can see there's been a long list of staging systems that have been developed. The BCLC system was first developed in 1999. It was then revised in 2003, and then it's been revised again in 2022. This is just a list of some of the staging systems and what they're really good at. And if you look, they say the BCLC system is the best at prognosticating patients that are going to be treated with potentially radical therapies. So the Barcelona Liver Clinic staging classification is based, and it's still based on the tumor extent, the size, the number, portal vein invasion, and whether there's extrahepatic spread, the liver function, the presence or absence of portal hypertension and jaundice, and the performance status. There are five stages ranging from very early to terminal stage, and we'll go through that. This was the 2003 updates, and you can see very early stage was 1 lesion less than 2 centimeters, Child-Pugh A, good performance status. Early stage, a single, regardless of size, or 3 nodules where none of them are bigger than 3 centimeters. Child-Pugh A or B, once again, a performance status of 0. The intermediate stage here was large, multinodular, child A or B, and performance status 0. And then advanced stage, basically any portal vein invasion, any extrahepatic spread, Child-Pugh A or B, performance status 1 or 2. And then terminal stages was if the Child-Pugh score was a C, or if the performance status was 3 or 4. So, as we know, one of the goals with in managing patients with HCC is to try and identify patients at early or very early stage, because that's when we can offer one of the curative intended treatment modalities. And we know that in sub-Saharan Africa, only about 5% of patients are diagnosed with stage 0 A or B disease. and that contrasts to Europe, where about 40% of patients are diagnosed with early or very early stage disease. So I'm just going to run through some of the weaknesses that were present before the update, and then we can look at how it's changed and decide if how much better it's got. So one of the problems with the terminal stage group is that all Child-Pugh C patients were put into the terminal stage group, and that was regardless of the size of the tumor. So if you had a patient who had a 3-centimeter lesion with advanced liver disease, they, according to this, should just get best supportive care. But we know that patients with advanced liver disease and a high Child-Pugh score are patients who do benefit from liver transplantation. So I think that was one of the weaknesses. Just because you've got a high MELD score, a high Child-Pugh score, doesn't completely rule out a liver transplant if you still fall within transplant criteria, or the transplant criteria that your center uses. So that's basically if a Child-Pugh C patient who's fit enough for transplant, within transplant criteria, diagnosed with a small HTC, would benefit from a liver transplant potentially. Then moving on to the advanced stage, portal vein invasion, extrahepatic spread, Child-Pugh A, this just recommended sorafenib, and we know that sorafenib is really not such a good drug. It does marginally improve performance status. It's quite expensive and not always well tolerated. And this was the original study that was published in the New England Journal of Medicine, and you can see the median survival of 10.7% in the sorafenib group versus 7.9 months in the placebo group. Very small benefit. Then moving on to the intermediate stage group, where the recommendation has been that all the patients should get chemoembolization. There's no mention here at all of SIRT or radioembolization, so that is a weakness. We also know that the intermediate stage group is a very diverse group of patients. Patients can be Child-Pugh A or B. They may or may not have cancer-related symptoms. There's no vascular invasion or extrahepatic disease. It can range from a patient with 4 tumors to loads of tumors bilaterally, and TACE is recommended for all of these patients. There's a number of studies that have shown that the intermediate stage group is so diverse that it can be divided into 3 or 4 groups, depending on which study you look at, and the treatments for those different groups in the intermediate stage can be quite different. Then moving on to early stage disease, so single or 3 nodules, where the largest is smaller than 3 centimeters with a good performance status. It doesn't take into account that different centers use different criteria for transplantation, and we know about this whole metro ticket concept that as you extend your transplant criteria, the 5-year survival does go down. But I think a lot of liver transplant units are now using extended criteria, and the BCLC didn't really take that into account. And the other thing is, I don't think it adequately takes into account which patients would benefit from ablation, resection, and transplant. It's a little bit too rigid and too simplistic. But what we do know is that, ablation is the least morbid of the curative intended treatment modalities, but probably the least oncologically effective, in the sense that it has the highest recurrence rate. Transplant, most morbid, but probably the best disease-free and overall survival at 5 years. And then another weakness when dividing patients into the different treatment modalities is that it just doesn't take into account tumor biology. And I think that's a problem. There's no consideration given to the alpha fetoprotein. Size of tumor is not necessarily, does not necessarily equate with bad biology. and it does not take into account response to neoadjuvant treatments such as chemoembolization or radioembolization. So let's have a look at this is the new BCLC criteria that was published last year, and I'm just going to go through it and see how it's changed, and if and we can just think about whether it's improved. So the terminal stage, they say it says very much the same here, but if you go read the article, they do make the point that if a patient is already listed for transplant with a high MELT score and an early HCC is detected, that patient should still be offered a transplant. So they have addressed it, although it's not actually in this diagram. Then the advanced stage group has changed. They no longer just say sorafenib, they talk about the newer agents that are available. I think one of the problems, certainly in South Africa, and I think in sub-Saharan Africa, is that most of these drugs are still not available. So although it's a nice thought that systemic treatment is available, it's not really practically available to most patients. I think they've improved things when it comes to the intermediate stage group, and that they've now, you can see they've divided it into 3. So they talk about, if a patient falls within the extended liver transplant criteria, that you would consider doing it. They talk about TACE for patients with well-defined nodules, preserved portal flow, and then there's some patients with intermediate stage disease who'd rather benefit from systemic therapy if it were available. Once again, not much mention is made of radioembolization. They do mention it down here as an option, but it's not really clear who would benefit from TACE, I don't think, and who would benefit from radioembolization. And I think that is something that this guideline doesn't really clearly address. And then there's really, I don't think, been any change that they've made in deciding which patients are allocated to the different curative intended treatment modalities. And I'm not sure that it's as simple as they make it out here. So in conclusion, the updated system does address many of the previous concerns, but a number of issues remain. I don't think it takes tumor biology into account, and I think that that's something that's going to become increasingly more important. It's very rigid, especially for early stage disease, and I don't think it makes adequate adjustments according to patient factors and disease response to neoadjuvant treatment. And I think there's a lack of applicability outside Western countries to a large degree. If you consider our practice, a lot of patients have hepatitis B, a lot of patients are non-cirrhotic, and I think we must just be careful to try and stick too strictly to the BCLC criteria. So I'm going to stop sharing. That's basically all I have to say. I'm not sure if there's any questions in the chat. So I see one of the questions from Enoch is, what are the reasons for the reduced diagnosis of very early or early disease in Africa? I've encountered a number of young patients who've been relatively asymptomatic, but then present with a short history of hepatic dysfunction leading to a diagnosis of advanced HCC, usually hepatitis B driven. So I think that's the experience of everyone who's working in Africa, and I think the problem is that these patients are infected when they're young. They don't even know that they're infected. They're not in a screening program. And the main way to diagnose early HCC is to have patients with known cirrhotic disease or known hepatitis B infection in screening programs. And that's just generally not the case. And then Mercy said HCC patients in Kenya tend to be AFP secretors. We see very high levels even in small tumors that can be resected. So our outcomes are still poor. So I think a high alpha fetoprotein does sometimes indicate tumor biology, but what we've noticed is that if you pre-treat someone with like a TACE or some form of neoadjuvant therapy like that, and you see a massive drop in the alpha fetoprotein, that's often an indicator that the patient will respond well to one of the curative intended treatment modalities. I'm not sure if there's any other questions. If there are, anyone can just raise their hand. I don't see any. So I think we'll move on to Dr. Ntunkulu's case. He is going to show us a case, and then we're going to discuss the indications for repeat TACE. Hi, Wang. I think you might be muted.
Hi, I'm Dr. Wang. I'm from the Grotesque circuit. I'm just going to show a quick case for us. We saw a 60-year-old female with no known comorbidities. Performance score at the time of presentation was 1. She presented with sort of vague abdominal pain, more localized to the right upper quadrant, loss of weight and fatigue, symptoms with duration of about 5 months. She has no history of alcohol use. At the time of presentation, she was not jaundiced. She was otherwise well, with moderate cachexia, with no other clinical signs to suggest chronic liver disease. On abdominal examination, there was this right upper quadrant mass. She didn't have ascites. Other systems were unremarkable. She's otherwise HIV negative. She's got previous exposure to hepatitis B. Hepatitis antigen, surface antigens were positive, and the cause were also positive. Otherwise, hepatitis C was negative. At the time of presentation, the LFTs, her bilirubin was normal, slight elevation of the ductal enzymes. And the alpha fetoprotein was 3. Other tumor markers were normal. So we proceeded to do a CT scan of her abdomen, which this is the arterial phase of the scan, which shows a mass predominantly on the right liver. There were some other satellite nodules on the left side in segment 2 and 3, with some cystic liver lesions as well that we can appreciate on the CT scan. And on the portovenous phase, the mass tends to wash out. On the arterial phase, she had her left hepatic artery arising from the left gastric artery. So we went on to discuss the case in our MDT, and the decision was to offer the patient TACE, and we also referred it to the liver team, where she was initiated antiviral, initiated on lamivudine. Patient was then decided to go for TACE. That's just the picture of the TACE. So the left, right hepatic artery was injected with Doxorubicin, and we also used Lopidol as well in conjunction with the Doxorubicin. So, and then after about 9 weeks, patient came in and we repeated the CT scan for her. This is the arterial phase CT scan of the patient, and you can already see in the areas of on the right tumor, there's some areas of necrosis, which would represent a poor uptake, which would represent a very good tumor response, and slight progression on the left side of the tumors, but the left side was not TACEd. So that's just the venous phase there. The cyst on the liver is still present. So just to give a brief on TACE and repeat TACE, most of our HCCs, they come in advanced stages of diagnosis with a median survival of about 6 to 20 months. And the mainstay of therapy here, that is curative, is surgery and liver transplant. But as we know, most of these patients always come in advance and they're not the candidates. And transplant, very limited resources to do that. As a result, most of the patient will fall into the TACE because they're not amenable to surgery or the transplant. So there's various other modalities that are used to sort of treat these patients, but TACE being the most commonly used treatment modality. The best candidate for the patient are those who have got unresectable disease without vascular invasion, and of course a good performance score, and would preserve liver function, and there must ideally be no extrahepatic spread, and they must have preserved liver function, that is child A and B. So essentially it's those patients with intermediate stage. Sometimes those in advanced stage C can be considered for TACE, but in select cases. But we do apply TACE sometimes in patients with who are candidates for transplant, is a bridge to transplant, and sometimes with surgery if we think that there's concern of liver volumes and we want to augment the liver volumes, and we can do TACE. Just want to clarify the fact that MDT is always very important, that every patient, be it for palliative intent or sort of these transarterial modalities, all these patients should be set onto MDT prior to any intervention. So the rationale for TACE is the fact that the liver has got dual blood supply, 70 to 80% of it coming from the portal vein and 20 from the hepatic artery. However, the tumors or HCC derives its blood supply almost exclusively from the arterial system. So therefore, if you do sort of a transarterial therapy, so you're likely to deliver dual action, so you can deliver the chemotherapy agent directly into the tumor without significant systemic side effects. And also if you can induce ischemia by blocking the artery. So that's the whole rationale of doing TACE. Often we use doxorubicin. I think that's the most commonly used drug, relatively inexpensive treatment modality. And TACE itself has got very low complication rate. One of the dreaded complication with it is patients can have post-TACE hepatic failure, and it's usually transient, and sometimes they can develop abscesses, but really mortality rate is relatively very low, less than way far less than 1% post-TACE, and the complication rates are also very relatively low. So the contraindication, the absolute contraindication is obviously if you've got a main portal vein thrombosis and you've got multifocal disease and advanced stage sort of chronic liver disease. Relative contraindication is patients with if you've got sort of hepatofugal blood flow or some form of collaterals between the right and the left system. If the performance score is poor, and if there's any contraindication to any sort of invasive arterial procedures. So just to look overall, these transarterial modalities, there's been some meta-analysis that have been done, but however, the studies are quite heterogeneous into the the substances used to do the transarterial management. But what is found is that the median survival with transarterial modalities of treatment for HCC do give some survival advantage of about 4 months as opposed to just bare supportive care. There's, however, very paucity of direct randomized control trials, about 2 that are found in the literature, and they also had very few patients. Some meta-analysis that was published in the Cochrane sort of disputed the survival benefit of TACE, but however, sort of meta-analysis, but not based on very high level of evidence, have shown that TACE does benefit patient in terms of prolonging survival and also symptomatic relief from pain, those who've got pain, and to halter tumor progression as well. So the other question is the patients with tumor tumor invasion into the portal vein. There are some select cases which we've done also in our units, and there's some Asian studies that have been done as well, where they've done sort of selective cases where there's a bit of tumor invasion into the portal vein or portal vein thrombosis. But ideally, it shouldn't be the main trunk, and it should also, if it's the main trunk, shouldn't be complete occlusion of the portal vein. And you can, in select cases, do this. This has been shown to also benefit patients as opposed to just best supportive management. However, I should clarify here that these cases need to be highly selected. The one thing also to clarify is the issue of hepatitis B. There's about 10% reactivation rate after TACE in patients with hepatitis B. It's not very clear as to why this happened, but it's postulated that the chemotherapy drugs might cause some kind of immunosuppressive effect that might sort of augment the reactivation of the virus. And so we therefore recommend that co-administration of antiviral is mandatory for those who've got hepatitis B virus co-infection. So in terms of evaluating patients post-TACE, so as a decision maker, whether we should proceed to repeat TACE or we should stop, the European guidelines and the modified RECIST, so they speak of the radiological disappearance of any intratumoral arterial enhancement, but there's a bit of discrepancy in terms of the reduction. The European Guidelines Association of Study of Liver Disease recommending that at least 50% decrease in the sum of product of bidimensional diameter of a viable target lesion, whereas the modified RECIST criteria says about 30%. However, if you use these two comparable, there's no difference in predicting survival. So either or, you can use these to sort of look at the response rate with the tumor. So there's various scores that have been published out there. The most recent one I found was that by Audret et al. This is about 2018, where they look at the Barcelona score, the alpha-fetoprotein, and the increase in Child-Pugh score by 2 points from baseline, and the radiological response time is one of the predictors or things that will determine whether we should repeat TACE or not. So just to mention again, these are the prognostic factors. So if you've got an increasing alpha-fetoprotein and you have to restage the patient, if the Barcelona clinic score progresses, perhaps you should consider other treatment modalities. And of course, if the Child-Pugh score increases by 2 points and the absence of radiological response, sometimes if there's no progress into the tumor, that can also be considered as a good factor. You can repeat a TACE then, So in our protocol here at Grooteskies, often what we do is we once we've got a patient, we sit in some form of MDT platform, which either be a radiology meeting in conjunction with a radiologist and hepatologist. If patient has been deemed irresectable, good performance score, and we look at the arterial anatomy in conjunction with the interventional radiology people, and we deem it fit or suitable for conducting TACE, and we usually do alpha-fetoprotein and the baseline LFTs. Then we'll consider the patient for TACE if the decision is to TACE, and we ideally repeat the CT scan in about 6 to 8 weeks, and also alpha-fetoprotein. I must just note that alpha-fetoprotein, the half-life is about 5 days. So ideally, one can repeat it in about 2 weeks' time. But we often call these patients to come back in about 6-8 weeks. We repeat the alpha-fetoprotein and we do the CT scan. If there's a good radiological response based on the modified RECIST criteria, and that's what we normally use at Grooteskies, or if there's stable disease and there's a decrease in alpha-fetoprotein, we can consider this patient for TACE. But if there's poor radiological response, in fact, with more of a progress of disease and increasing alpha-fetoprotein, if patient's performance score has deteriorated, or the LFTs preclude us, patient has become jaundice, we won't consider doing TACE. There's quite positive of data into when and how many TACE can be conducted. But on average, most patients in most societies will have 1 TACE up to 3 TACEs. But some people say you can't even do up to 4 per year, And whether how long one should continue is based purely on selective patient characteristics. If the patient after 2 years has been tased and there's no tumor progress, then ideally patient and there's a radiological resolution of the tumor, then they ideally should go back to the screening program if alpha fetoproteins have resolved. But ideally that we do it about 3 times. That's about how far we go at Groote Hospital. If there's any questions or discussions, welcome.
Thanks, Wanga. This patient of yours, did they get a repeat test? I didn't quite get that.
Yes, Mark. There was a repeat test.
Okay. And the response was the patient had a radiological response on the right side of the liver.
Yes, there was a very good radiological response. So I can just show you the first scan, the arterial phase before. This is before the TACE.
Okay.
See, there's extensive uptake there.
Yeah.
So that is this is the scan now post TACE, where you can see some areas of tumor necrosis and very poor contrast uptake on the tumor.
Okay. So on a site, Chiaka from Zimbabwe has puts a question saying, I would have thought multifocal HTC would disqualify this patient from TACE. So how would you respond to
that? So this is where now the guidelines become a bit sort of like limiting, So because this patient has got an obvious tumor on the right side, and this is what is likely to determine the prognosis, and this is what is likely to relieve the patient's symptoms, and that's why we often will do TACE on this patient as a purely palliative intervention, and we've done a few of them. We don't have data on what the survival is in our center. We're looking to look at that. We've done about 50 or so of these tumors, quite sort of outside the recommended criteria. And I must say, we haven't had significant morbidities from doing TACE from them, but we're still looking to look at outcomes. Yeah.
Okay. Yeah, I mean, I think it is the intermediate group, like I said when I spoke, is a very broad group of patients, and it's very difficult to decide how sometimes where patients should fit and who should get just TACE and who should just get. In our setting, we don't give a systemic therapy, so that would just be best supportive care. And I think one of the big factors is the performance status and the underlying liver disease. If you've got a patient with very extensive multifocal disease and like a Child-Pugh B, especially if it's a bad B, I definitely wouldn't do a TACE. But if you have a very well patient with good liver function, who's I think even if it's multifocal, you don't often lose it much by doing a TACE, and some of them do show quite a dramatic response. There's Chidi asks, does the size of the lesion affect the decision to TACE a patient? Wanga?
So if you look into the criteria, so they will speak of the size less than 7 centimeters, but we often disregard the size, as long as the arterial anatomy is suited and the portal vein is patent, we often go for it.
Yeah, I mean, I don't think there's a size cutoff from it being too big. Sometimes if you've got a small lesion and you're going to consider, well, when I say small, let's say you've got a 3 centimeter lesion that you're going to do microwave ablation on. Sometimes there's some evidence that the combination of TACE and chemoembolization is an option. So for the slightly larger lesions that we microwave, we would often TACE those as well. so that's, yeah, I don't think there's a size cutoff. And then the other question that he had was, do you continue systemic therapy after TACE? So I think I can answer that. I mean, like I said, we don't generally have those systemic therapies available. They're very expensive. I'm hoping that we will get them available. I know that there are studies that have been done looking at TACE plus the newer systemic therapies, and there does seem to be a benefit in some of those studies. But I'm not sure that it's something that's routinely done. I think if you had someone who had like on us, I was saying, like this patient with multifocal disease, at some point you probably would want to give them systemic therapy if it was available. And then Gideon Chongo has said, on what basis was the decision to use lamivudine based? Right. So, I mean, this patient's, we're all surgeons, so we don't get too involved in the hepatology side of things. But lamivudine is very well tolerated. Does not have any renal issues like tenofovir can do. These patients have a limited life expectancy. A lot of them are getting TACE, and TACE involves contrast administration, which also potentially affects your kidneys. So, you know, lamivudine brings down the viral load very quickly, and it's well tolerated. So that's why we tend to use it in this situation. And then Mercy Caroni says, what is the BCLC stage of this case? Looks advanced. So I think the BCLC stage, Wanga, was there portal vein invasion?
No, Mark, no portal vein invasion.
Yeah. So that would make it an intermediate stage. So so maybe benefit from sorafenib or one of the new biological agents. Once again, I think I revert back to the previous questions, is, you know, is there benefit of TACE and the biologicals? I think there is an overlap, and it's just a matter of getting that right. But like I said, generally not available to patients. I'm surprised that so many people have it available considering the cost. Are there any other questions? All right. So the next speaker is Dr. Sobnach. So Dr. Sobnach is one of our fellows, and he's actually doing his PhD on hepatocellular carcinoma. And one of the things that we always just think everyone with extrahepatic disease has got such a terrible prognosis, and we wanted to look specifically at patients with pulmonary metastases. So he's going to speak a little bit to that.
Good afternoon, everybody. Thanks for having me on this Gecko platform already. Again, today I'll be speaking about pulmonary metastases in HCC. We at our center, we have a database. Currently, our database 6 is set at about 523 patients with HCC, and 15% of these patients have pulmonary metastases. The real challenge we've had from the very beginning since I've joined is that we often see these very young patients who come in with a lesion in a non-cirrhotic liver that appears amenable to resection. But when we looked at their CT scan of the chest, there is an isolated pulmonary met or bilateral pulmonary mets that could potentially be amenable to some form of therapy, whether it be resection or ablation. However, we do currently consider pulmonary metastases as a kind of very poor prognostic factor. And you know, if anybody comes in with pulmonary mets, we would not consider them for curative intended therapies. So what we know so far is that hepatocellular carcinoma accounts for 90% of all liver malignancies around the world. It is certainly the second most common cause of cancer-related deaths worldwide. And for us, really, we are a hotbed of HCC. 80% of all HCC cases come from Eastern Asia and Sub-Saharan Africa. In Africa, HCC is the most common cause of cancer-related death amongst men. We know that it is a fatal disease of the young. The age standardized incidence is 41 per 100,000 in Sub-Saharan Africa. And in previous work by Mark Q, it even went up to 102 per 100,000 in certain parts like Mozambique. The median age of presentation is 45. Just to remind you that in North America and Europe and other high-income countries, the median age of presentation sits at around 65. So in that part of the world, it is really a disease of the elderly. The median survival in our region is 91 days. And for us, when as surgeons, when we think about this really has economic ramifications, particularly for our part of the world where we do rely on a young working population to advance our economies. So I think most of us have gone through the African Liver Cancer Consortium study. It was published in JAMA by Yang and looked at experience throughout various centers. In Sub-Saharan Africa, they had about 2,000 patients in the study. The data was quite superficial, but it did give us a vague idea of what really is going on. 84% had multifocal HTC in that study. 70% had stage D disease, and less than 1% could get a resection, RFA, TACE, sorafenib, or even a liver transplant. And the 5-year survival was 7%. What about extrahepatic metastases in HCC? Certainly in our database, we've seen some weird and wonderful presentations, ranging from an initial presentation of an HCC with a lump on the scalp that was biopsied and came back as an HCC. We've had a case where it came as a soft tissue swelling in the toe, biopsy came back as an HCC. But we know from the literature that the most common side is the lung. In some previous postmortem studies, up to 97% of the cases where the patient's demise of HCC, they were found to have pulmonary metastases. The other sites, those include regional lymph nodes, which we know well, bone. We've had a series of 10 patients in our database that have had metastatic spinal lesions, and 3 of them had complete, essentially like quadripresis, diaphragmatic mets, gallbladder, and to the stomach. These are probably more local regional lesions. And truly, the evidence for this is quite scanty. We currently have a young doctor who's registered for a PhD, and his PhD is entirely focused on the disease biology of pulmonary metastases in HCC at our center. And he's looking at he's conducting a population-based study. So this is one of the papers we quoted in his review. It's a BGS paper from 1998. It looks at prolonged survival in a selected group of patients following surgical resection for pulmonary metastases from hepatocellular carcinoma. And in this cohort of patients, 380 of them had liver resections, and 48 subsequently had pulmonary metastases. 11 had surgery. There were 9 males and 2 females. And the median disease-free survival between the hepatectomy and the appearance of the pulmonary metastases had followed up with 21 months. The median overall survival was 42 months, and the 1, 2, and 5-year survival was 100, 78, and 67% respectively. And that appears quite good, but one must bear in mind that these are patients who were treated initially with curative intent, but then developed pulmonary metastases. In a paper in the World Journal of Surgery in 2016, a Japanese group questioned the clinical significance of multiple pulmonary metastases in HCC, and really looking at the outcomes of doing multiple pulmonary metastatectomy for these patients. It was a small group. They had 19 patients, 14 males and 5 females. The median age was 61 years. So these patients are generally older than our population group. 8 patients had a single lesion, 4 patients had more than 10 lesions. The 1, 3, 5, and 10-year survival rates were 89%, 48%, and 21%. 7 of these patients had recurrences, and 5 out of them had repeat surgery. The median survival was 65 months, and the 2- and 3-year survival in this recurrence group was 160 and 67% respectively. In patients with more than 10 pulmonary metastases, the 2- and 3-year survival was 75% and 50%. So in a small group of, I believe, carefully selected patients at a center that deals routinely with resecting pulmonary mets, I think the results are indeed quite promising here. I just wanted to point out that there were significant differences in survival rate, and the main factor here was age. Younger patients below 60 did better than those who were above 60. And that might be of value for our population, given that our median age of presentation is 4 years. If we were to consider addressing these pulmonary mets in carefully selected patients, there might be some benefit from that angle. And then there's also this very interesting paper from the European Journal of Cardiac Surgery in 2012 that was an outcome and survival analysis of, again, pulmonary metastasectomy for HCC, 45 patients. 39 of these patients had hepatectomy and liver transplantation as definitive therapies, and 6 had local regional therapies. The median follow-up was 17 months. At 2 years, the disease-free survival was 19.5%, but the 5-year overall survival was 41%. And this is just to show you what a Kaplan-Meier looked at the study. And also, the survival rate was really influenced by recurrence. So if you had recurrence after your pulmonary mets were being addressed, that sounds quite logical. Your long-term survival was worse. Just to finish up, radiofrequency ablation for lung metastases, a very attractive option. This will now, not for HCC, but pulmonary metastases, and radiofrequency for pulmonary metastases will become available at our center over the next few months. And I thought it was worthy looking at this. This is quite a recent paper from 2020, looking at the effectiveness and safety in radiofrequency ablation of pulmonary metastases from HCC. It's a 5-year study. There were 42 lesions in 26 patients, 16 males and 10 females. Again, to note, the mean age here was 62.5. That's about 30% higher than what we expect in our population. BCLC stage C, patients were on sorafenib. And the outcomes are interesting. That one complication was subtle pneumothorax, and that was treated. Only one of these patients required an ICD. None of the patients had worsening in the pulmonary function, and overall survival, 1, 3, and 5 years was 89%, 70%, and 26%. So really, what is also important to consider in our context is that we really need to look at this in the very few patients we invest our time and resources, where we offer them, for example, patients who have a hepatectomy as a curative intended therapy. In the post-transplant group, certainly, as Wang said, we at our center are very, very aggressive with TACE. I think at the moment in the Southern Hemisphere, we're probably the group that's the most aggressive with that modality of treatment. And who are we to say that the patients who have pulmonary metastases, even in a palliative setting, should not be offered these therapies? Most probably in the realms of a trial initially. And there's another question, and which we've been debating very much in our group, whether it should be offered in combination with TACE or RFA for a primary lesion, particularly when there's a singular lesion in the liver. So I'm going to stop here, and that's it for me.
Thanks, Sanju. Just a question that I have. What about stereotactic radiotherapy for lung lesions?
So Mark, I haven't seen, I haven't seen that in the literature. I think Mohammed is the guy who's looked at that in depth. In fact, when I looked at the literature to try and screen some of the papers, these are the best I could find. They have recently looked at a meta-analysis now, and I think they've managed to get 30 good publications, which they're going to include. But I'm sure some people have done it as on a case-by-case basis. But I certainly haven't read about it. I haven't seen.
That's used a lot for colorectal lung metastases, and it is going to be available soon to us, so that might be also something to consider. But it seems to me, from what you've said, that it's quite a select group of patients who've been getting it, and it's generally after so it's patients who've had disease confined to the liver, have that treated with curative intent, and then develop lung metastases. That's generally the group of patients.
That's absolutely correct. But the other thing is, and you and I have had many conversations in the corridor on Fridays, where we see these young patients walk in. The liver is resectable, there's no question about it, and there's this one single nodule in the lung, and we say palliative care. It is really tough to. We've now started offering them TACE, but we know that's not curative. I suppose our population-based study will give us better direction. But like Prof Jonas has asked us from the beginning, can we treat these like pulmonary metastases from colorectal cancer? Can we do that? Is this something we should really consider? I'll tell you what we're doing in the lab. I mean, in the basic sciences lab, what we're doing at the moment is we've gotten exosomes from about 10 of these patients with pulmonary metastases, and we're doing RNA sequencing on them now to really see whether this is more aggressive. Are there more, do you see more mutations in these patients than the ones who don't have them? So from a biological point of view, we should also try be getting some answers. But Mark, the other thing I must say is that in the patients we've offered TACE with pulmonary metastases, so far, I must say, so good. There are about 5 patients who are now going to get the 3rd round of TACE, who are about 6 months out, who have improved very significantly. So, it's really a difficult situation. But I think we know this. The problem is these patients are so young.
Yeah. Okay, that's very interesting. Thanks very much. I don't see any more questions on the chat. So if there are no more questions, I think we will end it there. I'd just like to thank the speakers, Dr. Ntumkulu and Dr. Sobna. And thanks to the eIcho New Mexico and eIcho India team. Recordings of this are available on the Gastro Foundation website. Thank you to the Gastro Foundation, and thank you to the sponsors. Thanks very much, everyone.
Thanks, Mark. Thanks, Sanju. Cheers.
Thank you very much.